Okay, I'm going to talk about improving observational studies and some techniques that we might all benefit from. I thought this is an epidemiology audience, so that this would be a good fit for this crowd. I also wanted to make the point that it's going to cover a lot of domains, some cancer, some beyond cancer, but we'll get into it. So, improving observational studies, and I'm a professor here in the department. All right, so one of the things that I hear often when we talk about observational studies is when are randomized trials necessary? When are they not necessary? Are they useful? Are they helpful? Under what context? And people often toss out two examples. They say, did you know? We believe smoking is harmful. We advise people not to smoke. But it turns out that belief was not based on randomized controlled trial evidence. That belief was based on really well done observational evidence by Bradford Hill. So that's an example of where you have a causal belief that you never had a randomized trial for. Another example is a parachute. If you're going to jump out of an airplane, we all would want a parachute strapped to our back. That would be crazy to jump out of an airplane without a parachute. But that's also an intervention that, strictly speaking, was not studied in a randomized trial, 1,000 people parachute, 1,000 people no parachute. So we hear these points made often in the epidemiology community that randomized trials are not always necessary or useful or helpful or ethical. But is there a framework that we might be able to make sense of it? Can we put this all in a single conceptual framework? And that's what we tried to do in this paper a few years ago with Logan Powell from Texas. Here's the framework I offer you. You tell me what you think. I say, let's imagine a spectrum. And this spectrum is from like the worst thing you can do to somebody for their health to the best thing you can do to somebody for their health. And in the middle is just no net effect on their health. Absolutely not going to change it one way or the other. So what's the worst thing you can do to somebody? What's the best thing you can do to somebody? And then what's like smack dab in the middle? So let's just come up with something. So like, what's the worst thing you can do? I always ask the audience, like, what's the worst thing you can do to human health for someone? And they often say, like, you could shoot that person in a vital body part. I was like, oh boy, you guys got dark fast. You could hit the person with a car. I was like, okay, well, easy. And then I once gave this talk to a nursing audience, and somebody shouted from the back, you could push potassium in the IV. And I said, well, you said that a little too fast, if you ask me, a little too fast, okay? That was a little fast. So I got a little nervous. Okay, we can all imagine something you do to somebody that's extremely harmful, kill them right away. What about help somebody? You could wear the parachute. Parachute has an absolute risk reduction on all-cause mortality of 99.9999997% in 15 minutes or 10 minutes or 5 minutes. I mean, the huge absolute risk reduction on mortality and a very short time window. What if you see me at the bus stop in front of Mission Hall and I'm looking at my phone and you push me out of the way and the bus whizzes past? I'll say you saved my life. Okay, so I think these are the most extreme things, the most harmful thing you can do to somebody, the best thing you can do for somebody. And I just want to point out that for these things in our lives, not only do we not have randomized data, we don't even have observational data. I mean, you just have anecdote. The first time somebody got shot in a vital body part, we're like, okay, that's not so good, right? So for very big effect sizes, you can use the naked eye. What about smoking? Smoking in Bradford Hill's study for lung cancer, the odds ratio is 20. That's actually massive. Massive odds ratio smoking increase to lung cancer. What about smoking in bladder cancer? It's like 2 to 4. Okay? What about eating bacon? Eating bacon in meta-analytic estimates is like 1.75 odds ratio. It's much closer to no net effect. Here I'm talking about bacon once a week added to your diet. And even that, I don't know, do I believe that? Is that a credible finding? We'll talk about. This is where we do observational studies, I think. I think we do observational studies for putative harms and putative benefits for effects of modest to marginal effect sizes. This is where we use observational research to help us. Is it a good idea to, smoke? Is it a good idea is some new pollutant causing lung problems? Is air pollution linked to coronary vascular disease? All these things we could use observational studies for. Randomized studies, I think, have a unique place. They are typically used for interventions of a putative benefit. We don't typically randomize people to putative harms to demonstrate they're harmful. We have not done that for smoking. We've not done that for benzene in the water. We randomize people to putative benefits, like taking this pill, this statin medication, or having this device placed in your body. And we do so for modest to marginal effect sizes. We don't do so. Modest to marginal effect sizes, putative benefit, this is the place for randomization. This is the ideal place for randomization because it can separate hope and hype from real effects. So let's take a look at some of these things. I think when we think about causal inference, we're really concerned with 4 key questions. We're really concerned with, is the finding reliable? Like, you want to do a causal inference study where the answer is something you can hang your hat on. Yes, taking metformin does lower your A1C. Yes, or it doesn't. Taking metformin increases your life expectancy, or it doesn't. We want to know the answer as cheaply as possible. We don't want to spend a lot of money. Randomization is very expensive. But observational studies are expensive in its own way, which I'm going to show you. We want to get the data, we want to get the answer to the question as quickly as we can, have a fast estimate, and few. Few here means that sometimes interventions work and sometimes they don't work. And what you want ideally is, in the process of figuring out if it works or not, to minimize the number of people who are ultimately exposed to what was inferior. You want to minimize exposure to the ineffective drug or the placebo, or if the drug doesn't work, maybe you want to, or is harmful, you want to minimize exposure to the drug before you figure out that it's harmful. So we want to minimize bad outcomes to participants in research, and that's what I mean by few. Okay, so we wrote this paper, Reliable, Cheap, Fast, and Few. Let's think about these 2 things. So are observational studies reliable? We talk a lot about confounding. We don't talk enough about time zero. We don't talk enough about analytic flexibility. So let me get into some of these things. Actually, I'll skip time zero. This group knows time zero. Let me talk about analytic flexibility. So confounding, of course, is the general premise that there is something different between the group that did something and didn't do something. I'm going to give some examples from the vaccine effectiveness literature later, where it's pretty clear that people who go out and get the next booster right away, they're different in other important ways for health than people who don't get the booster right away. And so you can look at COVID-19 outcomes in those people, and some of that may be the effect of the booster, but some of that might also be the type of person who rushes to get a booster. That's confounding. Time zero, of course, is when you had to live long enough to get a certain product. If you die right away, you can't get it. So observational studies of people who have COVID-19 in the community who fill a Paxlovid prescription and get the Paxlovid, it has guarantee time, which is the time to get the Paxlovid. If you were hospitalized immediately or you died before you could fill that Paxlovid prescription, you, by definition, cannot be in the group that got Paxlovid. And so that guarantee time has to be accounted for in observational studies of the efficacy or the effectiveness of Paxlovid. Now, what about multiplicity and analytic flexibility? So here are some interesting results we've seen recently. This was a paper by Brian Nozick and colleagues from the University of Virginia. They took a data set, an Excel spreadsheet, and the Excel spreadsheet kept track of the European soccer games. And they knew anytime a player played, who was the referee, and whether or not that player got a penalty card, specifically a red penalty card, a red card. And for every one of the players in the European Soccer League, Nozick's team of investigators looked at a photograph of them and assigned their skin color and number from 1 to 5, 1 being very light-skinned and 5 being very dark-skinned. Okay, they put that in the data set. So now you have a data set of who got red cards and one group of people scoring skin color. They gave this data set to 29 research teams. These were good research teams. The teams were asked to sort of explain your statistical analysis plan and ask the question, are referees more likely to give dark-skinned players a penalty card? And this was the result of their study, which was the same data set, the same soccer games, the same penalties, 29 different research teams who are experts at data analysis, the same question, and you see it's equally likely. There is no bias in multiple estimates. With a point estimate, maybe if anything, white people are more or lighter skinned players are more likely to get penalty cards. 2, they're 3 times more likely, 2 estimates, and then a whole bunch of estimates in the middle. Same data set, different conclusions. Some of these are statistically significant, some are null. So this was a very provocative finding, suggesting that analytic flexibility is very important in observational research. It was followed up just this year in the PNAS. This is 90 different research teams asked a simple question, same data set. Is there an effect in a negative direction, a positive direction? And what you see here is the range is even wider. That some people think there's a negative association, some people think there's an association, and you get point estimates all over the place for the average marginal effect. I think in part, the fact that analytic plans can give you such divergent estimates is in part why the lay public complains that the medical news feels like this. When you open the New York Times Well column, it so often feels like, how did they write this column? They spun the wheel, and today we're going to talk about coffee can cause, spin the wheel, depression in twins. According to the news report today, coffee can cause depression in twins. And one day, It's coffee can lower the risk of heart attacks, and the next day it increases the risk of heart attacks. The news keeps flip-flopping on these topics. So why does that happen? This is a true story. One day I opened the newspaper and I saw that vitamin E increases all-cause mortality. So I went to my cupboard and I threw out all those vitamin E gel caps that I had saved up. But unfortunately, I acted too fast because the next week the vitamin E mortality study was challenged, and actually vitamin E was found to be improving survival. So I was in Costco lined up to get the biggest bottle of vitamin E you've ever seen. So why does this happen? I think as we all know, and at least on this call, that investigators doing this kind of research typically have an observational data set, such as the NHANES data set, a food frequency questionnaire, that also knows many years later if somebody's alive or dead. And the way we do this research is we construct some type of model, but typically the model is a regression model, where the first covariate we put in is the thing that interests us, vitamin E exposure. And so you ask, is there an association between vitamin E exposure and mortality? But of course, you have to adjust for covariates. And I so easily could say, let's adjust for age. After all, older people take more vitamin E capsules. Let's adjust for sex. Let's adjust for race. But somebody else could do the same sort of study and also add income. Maybe they live in Toronto and they're more cognizant of income. And somebody in North Carolina might add smoking status. Okay? And then my friend at Harvard, he might add BMI and hypertension, diabetes, cholesterol, alcohol consumption, education, family history, heart disease, etc., etc. So there are many different analytic plans that could be run in the same data set looking at vitamin E exposure and mortality. You could run it with 2 covariates, 3 covariates, 6 covariates, or 13 covariates, or something like that. And you can also run it with all sorts of combinations of these covariates. And a few years ago, researchers at Stanford realized that for observational nutritional epidemiology or any observational claim, what you often have is many investigators have access to the data, and they're all probing the relationships all the time. Each of the investigators is adjusting for some set of covariates that make sense to them, that they've created a story why these covariates are important to adjust for, and their covariates they're not adjusting for that don't make sense to them. And they asked, instead of looking at one paper here, one paper there, what if you simulate the entire research community? You simulate 20 years of people looking at beta-carotene and mortality and vitamin D and mortality in the NHANES data set with all of the possible covariate combinations they could be looking at. And this was the paper. They took NHANES in those years, they took all the variables of interest, and they started to pick one at a time, things like vitamin D, beta-carotene, lycopene, which is in tomatoes, the most common associations you see. And they picked the 13 most common covariates that researchers in nutritional epidemiology adjust for, socioeconomic status, education, race, BMI, and they didn't just do one regression analysis or even 3 or 4 in sensitivity, they did every possible combination, 2 to the power of 13, 8,000 models, so every one of these individually, all of them together in every possible combination. So what they are doing is simulating 8,000 research studies from the same data set on the same question, vitamin D consumption and all-cause mortality. Okay? I think it's kind of a clever paper. Here's what they find. This is Chirag Patel, Belinda Buford, John Ioannidis. They're plotting you a heat map of 8,000 studies. Each of these panes, A, B, C, and D, is a different nutrient. On one axis, they're showing you the hazard ratio. Hazard ratio 1 means no association. Above 1 means it's deleterious. Below 1 means it's beneficial. On the other axis, they're actually plotting negative log 10 p-value, a measure of significance. So the further it is away from the center, it's more likely to be significant. And what they're showing you are these clouds of association, this heat map of all the possible studies. And every time the New York Times writes up one of them, they're writing up the one in the upper left or the one in the bottom right, etc., etc. They're not telling you the whole story. Can anyone guess what hazard ratio has most of the heat of these nutrients sitting right on a certain hazard ratio number? What's the most common number that all these studies are sort of honing in on? The majority of the analytic plans say vitamin D, beta-carotene, what's that hazard ratio? The hottest spot on the map for most of these things. Any guesses? You can put it in the chat and shout it out. 1, that's right. The hottest spot on the map is 1. For most things, most analytic plans do not have any association. However, you can get statistically significant benefits and harms for at least 40% of these studies with these covariates, 40% of nutrients. And their point is that think about all the selection filters that go into publication. If Allison runs an analysis and she finds beta carotene is absolutely null, she might not even decide to present it at lab meeting. She's like, it's such a boring finding. Who's going to want to publish that? If she also finds that the hazard ratio is 0.1, that's too good to be true. Beta carotene might be good. It's not going to be that good. So it's the 0.7s, the 0.8s, the 0.6s that are very provocative. It's plausible. And then she may only tell me these, and then I may only write up the ones that are robust in sensitivity analysis, and the journal may only publish the ones that, they think are plausible and interesting. And I think the net result of the ecosystem is if you have 10,000 people analyzing these questions over time, the published literature may not be a reflection of what people are doing, may not be a reflection of the most common analytic outcomes. It's only a reflection of the filters that are in place in science which reward, discovery, which reward claims. And what you find is that the published literature is not the truth, but rather an opinion poll as to what doctors and scientists think are plausible. And that's why when the same researchers took a DART, that's publication bias. Yeah, I think it's selective reporting bias in terms of what we write up, and it's publication bias in terms of what we select. So the same researchers took a DART and threw it at a cookbook, the Boston Cookbook. They landed on these ingredients. They looked them all up in PubMed. These are randomly picked ingredients from a cookbook. And they asked, are there studies in PubMed that link beef to cancer? And yes, there are many that increase the risk of cancer. There's also a few that show it lowers the risk of cancer. And that's true for most ingredients except for things like olives, which everyone think are good for you, and bacon, which everyone thinks is bad for you. But for most things, you can find statistically significant associations in the literature for cancer, positive or negative, that these foods can do both. And if you look at the Z distributions of these things, what you find is, of course, it's clustered around negative 1.96 and positive 1.96 among the studies. The middle is scooped out entirely. And that's very likely because that's the magic number. The P of 0.05 number is the magic number that gets you into the journal. And if the magic number was a different number, if we changed it to P of 0.04 or 0.03, after all, it is arbitrary, then I suspect you'd have a different clustering of the Z-scores in the published literature. And I think what they're telling you here is that basically you've had 10,000, 100,000 people doing analytic plans on some of these questions for things like coffee and green tea and berries. There may be 100,000 analytic plans run, and there may be 10,000 papers in the last decade on berries and health outcomes. But does that 10,000 represent the most common outcome, or just the outcomes that people were most interested in writing up? Okay. I think multiplicity is a huge problem. And once you get many, many people analyzing questions in many, many data sets in an observational fashion, and if there is a dispute in the field, you will get both answers. You will always get both answers to the question, does this help or hurt? If some people think it does, some people doesn't, and there are many, many people probing the question. But then I still don't know the answer to the question. So let me show you some of the sort of seminal papers in this space. Then we'll talk a little bit about COVID. There have been multiple comparisons of observational studies and randomized controlled trials on the exact same clinical question. This was one of the first ones in 2000 in the New England Journal by Benson and Hartz. There's a paired paper by John Concato and colleagues, and they basically ask for the same question where you can find observational studies like, does calcium channel blockers improve outcomes for people with coronary artery disease? There's observational literature, there's randomized data. For those questions where you have both, what is the concordance between the two? And this is a long genre of literature. There may be now hundreds of studies in this concordance, bigger and bigger studies looking at more and more topics for which they're both. One caveat is, it's already a select group. I mean, in order to be in these concordance studies, researchers had to do it both ways. There are many questions we don't have randomized trials on. There are many randomized trials that we don't have a paired observational study on. So this is the fraction where we have both. And what you find is, this is a different figure from a paper by David Kent where they looked at propensity score matched observational studies. What you find is you typically find a figure like this. Each dot is an intervention, like, does taking a statin improve survival in people with colon cancer? That's a dot. On one axis, they plot the relative risk in observational study. One is null, less than one is beneficial, above one is harmful. And on the other axis, they plot it in the randomized study. And what you want to see is all the dots would line up on that solid dotted line in the middle, that hard dotted line. And what you find, though, however, is there's some discordance. Sometimes it's not like they don't agree at all, but sometimes they don't agree. This is the challenge. This is another paper by Sony and colleagues. This is just cancer trials, so something closer to my space. Same kind of plot. You see this cloud of differences. We can talk about whether or not both might be true. Sometimes both might be true, but I'm going to give you some examples where they're really trying to ask the same question. And these are the quadrants where they have the same take-home conclusion. Yes, you should do it, lower left. No, you shouldn't do it, upper right. Those are harmful by both study designs, and these are harmful by both study designs. But the problem in medicine is that you often get these quadrants. If you believe upper left, observational studies, you'd say don't do it. But if you believe the randomized trial is actually life-saving, and if you believe lower right, the observational study would say do it, but the randomized trial would say harmful. And I think the challenge with reliance on with observational data is that, I think which is true. I know epidemiologists like to say maybe the randomized trial is wrong. I think sometimes it is the randomized trial that's wrong. One was Paradigm, which was, I think the randomized study is wrong, the observational literature is right. But sometimes it could be the observational study that's incorrect. Only 40% of the time do the matched pairs report the same take-home conclusion in a statistically significant fashion in that paper. Okay. What I find interesting is when the randomized studies find the observational trial doesn't work, typically they say it's null. This intervention doesn't work. The observational study...
Top search results.
Okay, thank you, Google phone. The observational study is typically reporting a hazard ratio of 0.8. And to me, the reason why they're using 0.8 is that 0.8 is just what is the most plausible hazard ratio in oncology because it's the hazard ratio we're used to getting. We're not in the 0.2 business in oncology. That's too good to be true. And we don't want to be in the 0.95 business. That's kind of meager. We like to be in the 0.8 business, and that's indeed what we get in the observational studies. Okay. A couple years ago, Rahul Banerjee, who was a fellow here, and I wrote this commentary in JAMA Network Open where we were commenting on a different study, and this was kind of a more clever study. Here's what the authors did. They took 190 clinical guidelines questions from oncology, where there was a randomized control trial that was the basis of the clinical guidelines, and the only basis of the clinical guidelines was a randomized control trial, 190 questions. And for each of these questions, they tried to emulate or mimic that trial in an observational data set using hospital-level data in the EHR data set. So they are actually taking a set of questions, and they're running all the observational studies themselves. And I think they're using propensity score weighting in this analysis. And for each of these clinical questions, they're trying to replicate it as closely as possible. Okay, this is nice because we're not looking at the published literature for the questions that happen to have both study designs. We're explicitly creating the observational study when it doesn't exist. And here's what they find. If you look at the observational studies, 55% conclude that that practice is beneficial. Yes, you should give radiation. Yes, you should do surgery. Yes, you should give the drugs. 45% says it doesn't work. But if you look at the randomized data, 40% of these validate the practice among the beneficial ones. They're beneficial. And 67% of them validate the practice among the ones that don't work. The point I want to make here is that if you claim there's a benefit, it's much less likely to be true in randomized fashion than if you claim there's no benefit. That's much more likely to be true. But of course, there's discordance in both ways. There are things observational studies think work and they don't work, and there are things that the observational study says doesn't work, but it actually does work. That's rare. And if you pool it all, this is the result, I think. About 1 in 3 of these interventions actually work in randomized fashion. 2/3 don't work, but the observational literature is generally more optimistic. Now, why is that the case? I think it's confounding by indication. In oncology, our therapies are not benign. They are tough. They may increase toxicity. They may make it harder to get out of bed. They have side effects. And if you see somebody in your clinic and you still prescribe them the medicine, what you're saying is, I think you can tolerate the side effects. I think you can take the side effects. If they're really frail or vulnerable, often you say, you know what? I don't think you're a good surgical candidate, or I don't think you should be getting radiotherapy, or I don't think I want to give you this medicine. And because we give our more aggressive therapies to people who pass our eyeball test, look better, I think you often find in observational data that these interventions look like they improve outcomes simply because doctors like to deploy them in the healthier looking cancer patients because we're worried about killing the ones that are too frail. And I think that's why the observational literature in cancer, at least, has this upward bias. Our interventions look better than they are. Okay, so that's reliable. I mean, I don't have the answer to the reliable question other than as long as we have such high rates of discordance, we will have to take both with a grain of salt. I think the way to settle it would be multiple randomized control trials on the same question with more and more pragmatic designs where you really replicate the real question, which is, does this intervention work in populations that we're deploying them in? And we've seen some of that with Recovery, the UK randomized study in COVID. Okay, let me talk for a minute about the cost. You know, the thing about randomized controlled trials is it costs a certain amount of money. Do you see studies appropriately taking confounding medication into account? No. I mean, I think that there are many oncologists who do like very aggressive things to patients based solely on observational studies. Like we are giving chemotherapy based solely on observational studies to people. We don't have randomized studies. There's not even a call for randomized studies in some settings. And they're not considering the fact that that chemotherapy might not be working. And the only reason it works in observational fashion is, well, you didn't give it to the sickest people. And to me, giving somebody like 8 months of chemotherapy or 4 months of chemotherapy should not be taken lightly. I mean, it's not a fun thing to do, to get for no reason. And it has increased risk of secondary cancers like leukemia and other things like that. And so I'm much less likely to advocate for those things. Let's talk about price. Anytime you randomize somebody, it costs a certain amount of money to run a randomized study. My colleagues in the industry say that with current industry standards in oncology, it's $50,000. $50,000 for each person to be randomized, just in administrative costs. I say that's ridiculous, you know? The Europeans are better than us. They're able to do randomized controlled trials for as cheap as $50 per person. This is a Dutch randomized study called TASTE, a study of catheterizing people after a heart attack. But let's say we're $50,000. Using the equation at the bottom, which I derived, I want to make this point to you. There's a tipping point. Okay, it costs money to put people on on a randomized study, but in an observational study, typically, you have to give the intervention to more people before you come and do the analysis. Somebody had to pay for lots of people to get an intervention, like get a statin or get a medication, and then we come later and we do the observational analysis. Who is that somebody? Typically Medicaid, Medicare, insurance company. So if I start to give chemotherapy to people with, a type of cancer we don't give chemotherapy to, 5 years later you come along and say, let's do an observational study to see if that chemotherapy worked. I probably gave it to a lot of people over those 5 years. And it turns out if you look at these concordance studies that I showed you, the ratio is roughly 15 times the size. 15 times more people get an intervention in the real world. I'm sorry, not 15, 6 to 8, half of 15. More people get an intervention in the real world, in observational data, before you run that study on the back end to see if it works, than would have gotten it in a randomized study. Because randomized studies have strict power calculations. So for instance, if I want to know if COVID-19 vaccines work in a randomized study, the sample size is 20,000 per arm. But if I want to know if they work in the real world, the sample size is 20 million per arm, that kind of thing. That's what I'm getting at. So how much does it cost to give an intervention to all those extra people you give it to if you're only using observational data to answer these kinds of questions? Well, it depends on how much that intervention costs. And so this table basically is the break-even point. And what it's showing you here is that if it costs $50,000 to randomize a person, it's always cheaper to do the randomized study if the intervention is less than $8,300 per person. More than $8,300 per person. If the pill costs $9,000 a person, it's cheaper to do the randomized study to get the answer than the observational study. Because in the observational study, you got to pay $9,000 per person for the pill to a lot more people. That's the calculation. And it turns out in cancer medicine, all of our pills cost more than $9,000 per person. They cost $200,000 per person. So in cancer medicine, it's almost always cheaper to do the randomized study than just let products debut. But it varies. I mean, you could argue that, vitamins and minerals and aspirin, it's probably cheaper to do the observational study. Sure, I'll give you that. But for some interventions, depending on the price of randomization, this is the break point what we calculated. And my only point here is that sometimes people's intuition is wrong. It's actually cheaper to do randomized studies from the point of view of payers. I mean, ultimately, the government and all of us pay for a lot of these things either way. Let's talk about fast and few. Years ago, a woman had breast cancer. If the breast cancer is just in the breast, we'll remove the breast with a lumpectomy or mastectomy. Sometimes the cancer has spread to other parts of the body, and in this case, what do we do about the breast? And somebody got this idea that, even if it's spread to the lungs, maybe we should cut out the breast cut out the breast mass, maybe it'll improve survival. Maybe the breast mass is driving the tumors. Maybe the breast mass is going to be seeding more cancers elsewhere. Maybe the breast mass is going to kill somebody. And if we remove that primary breast in somebody with metastatic disease, maybe we'd increase survival. Well, this idea was very seductive, and surgeons started to like this idea. They said, why not? We do operations on localized cancer. Let's do operations on advanced cancer. And there have now been many meta-analyses to determine if surgical resection of the primary tumor in the setting of advanced breast cancer impacts survival. And these analyses have lots and lots of papers in them. And basically, they find generally that surgery does work. It really, really improves survival for a woman with metastatic breast cancer in a meta-analysis of many, many observational studies from healthcare systems. I mean, we're talking about like 30 plus. But a few years ago, they actually did a randomized control trial. One of the two was done in India. And they actually randomized women to the surgery or no surgery. And these were the results. If you did the breast surgery, you didn't live any longer than if you didn't do the breast surgery once the horse had left the barn, once there was metastatic disease. So now we have a discordance. The observational studies say it works. Not only does it work, it's like a huge reduction in death. The randomized study says it don't work at all, and the curves are basically superimposable. The observational studies collectively performed this surgery on 28,000 women over 35 years in many healthcare systems. The randomized trial took 350 women to be randomized and took 10 years to run, which was very long. But the observational study actually cost 500 times as much because surgery is not cheap. And the observational study actually ultimately exposed at least 15,000 more women to the ultimately futile surgery than the randomized study. So my point here, on the fast and few part, is that sometimes randomization is actually faster because it settles a question in 10 rather than 30 years, and sometimes fewer people are ultimately assigned something that's harmful. I can tell you that getting your breast removed when it's not going to improve your survival is an iatrogenic injury. You should not do that to somebody. You shouldn't put somebody through a surgery that won't improve their outcomes. And yet, over decades, we put tens of thousands of women through that surgery because people believed it worked without actually running the study. And that just came out a few years ago. All right. So randomized studies are over here in my mind. And I think the reason why I am such an advocate for them is that for interventions with a modest to marginal effect size, I think they are reliable. I think they can be reliable if done well, not always. But they often offer other advantages. They are cheaper and expose fewer people to ultimately harmful things. Okay, I'm going to skip the parachute part for the sake of time. I'm going to talk about ways to improve. One thing we can do in observational studies that will improve our studies a great deal is falsification endpoints. What do I mean by that? Let's say you had a question, does getting and for the sake of argument, let's say the first 2 COVID-19 shots, we'll call that vaccination. The third shot we'll call the first booster. The fourth shot we'll call the second booster. The fifth shot we'll call the third booster. And then we went to the bivalent booster and we got 2 years of bivalent boosters. Okay, so you can get like 5-6 shots now. Now let's say in the first time we ran the study, we did do a randomized control trial in the Pfizer study and the Moderna study. We had a randomized control trial, 40,000 people. We have a primary endpoint of symptomatic SARS-CoV-2, meaning you got symptoms, and we swab you, and it's COVID, and the vaccines were gangbuster good. 94%, 96% reduction in symptomatic SARS-CoV-2, and a statistically significant reduction in severe disease in Moderna, an imbalance of like 30 to 0 in the first study. It looked really, really good for the first 2 doses. But people looked at the first 2 doses and they pointed out that a lot of the benefit came from dose 1. That after dose 1, you had already basically flattened, quote unquote, flattened the curve of symptomatic SARS-CoV-2. Did dose 2 add much? I don't know. It was an open question. I think some of us were a little bit concerned that dose 2 in younger populations might have been overkill. Did a 20-year-old man need dose 2? Certainly there were downsides. There was risk of myocarditis. There's risk of adverse events. Did he get a further reduction in severe disease? Now we get to dose 3. By the time dose 3 and 4 and 5 came out, and the most recent dose, there are no randomized studies anymore powered for clinical endpoints. We don't know that this year's bivalent booster reduces the rate of symptomatic SARS-CoV-2 in a randomized study. we use observational studies. Well, one of the things that might happen is that the type of person who gets the new booster might be different than the type of person who doesn't. They may be more likely to not go out and less likely to go to crowded indoor places, and they may be better health. They may be richer. They may have different socioeconomic status. They may vote for different people. They may even get into car accidents less often. Imagine that. If you could see that people who got a booster were less likely to get into car accidents, that would be a strong argument that they're different people, that there's residual confounding, and not that the booster lowers car accidents, because I don't think anybody, even the most ardent proponent of vaccines, thinks that a vaccine can reduce your risk of a car accident. So if you run a vaccine effectiveness study, and you also look to see are car accidents the same in your boosted, no boosted group, that's what we call a falsification test. You should not see a link between vaccination and car accidents. And if you do, it suggests that there's residual confounding. You see the point? Because how the hell can a booster keep you out of a car accident? It just tells you that you're a person who is, maybe you're not driving as much, you're not taking the same risks, you have a higher socioeconomic job where you're not in the car as often, and maybe you have a better car, the car with all the safety features, the Volvo stops itself, I don't know. And indeed, that's what they find. Don Redelmeyer and colleagues, COVID vaccine hasn't seen long-term traffic risks. They look at millions of people, and they look at the rate of car accidents among people who got the vaccine, the primary series or no primary series, and they find, lo and behold, there's a big difference. If you don't get the vaccine, you have way higher car accidents over time than if you do get the vaccine. No vaccine. Well, the booster studies don't report falsification endpoints. There's many that have come out of Israel, and they don't report falsification endpoints. They don't tell me about car accidents, and they don't tell me about rates of other endpoints thought to be unrelated to, like you could even look at like lung cancer death. Lung cancer death shouldn't be any different because, that shouldn't vary. They don't tell me these things. But we accidentally found it out. So this was a correspondence we wrote in New England Journal where the Israelis reported two things. One, the reduction in COVID-19 death from boosters, which was like a 90% and like massive reduction in COVID-19 death in their observational data set, this Claret Health Services in Israel, which covers most people in Israel. And then in a subsequent paper, they reported the death from non-COVID-19 causes, dying from other things, not COVID-19. And that was 95% reduction compared boosted to non-boosted. So is it possible that boosters reduce your risk of COVID-19 death 90%? Yes, that's possible. But is it possible they also reduce your risk of all those other causes of death, cancer and heart disease and car accidents by 95%? No, I don't think that's possible. That's too good to be true and not biologically plausible. So if they have a 94% reduction in non-COVID cancer death, do you think I can trust the 90% reduction in COVID death? Absolutely not. The study is hopelessly confounded. You're comparing, in this case, wealthy people with access to healthcare systems who rush to get boosters, who are very precautious and do other health behaviors that are precautious, against people who are nothing at all like them. And proof of that is non-COVID-19 death is even more skewed than COVID-19 death. It's even bigger differences. And so we wrote this up in New England Journal, and the authors didn't really have much to say in response. I think they pretty much conceded the point. But then my point is, well, if I can't hang my hat on this study, I can't hang my hat on this study. And I have been a big proponent that the annual booster needs an annual randomized study. One more thing you could look at an observational study. This is the original randomized controlled trial of the Pfizer-BioNTech vaccine versus placebo. The primary endpoint here is symptomatic SARS-CoV-2, means I feel sick and Pfizer tests me and I have COVID. The line goes up. And as you can see, placebo is firmly defeated by the BioNTech vaccine. I mean, this is amazing. Okay, it's a huge win. Huge win. This is symptomatic SARS-CoV-2. Big win. Okay, here's the point I want to make. How many days does it take for the curves to separate? How many days after dose 1? And if you'll agree with me, it's like 10 days. Before 10 days, the curves are superimposable. At 10 days, they separate. Well, that makes a lot of sense to me because the vaccine, not magic. It's not a force field. It has to go in you and you have to get sore and you have to make antibodies and you have to like rev up your immune system. You have to learn to fight it. And then you have to get exposed to COVID and the COVID has a little incubation period and then you have to have less COVID, right? Less symptoms. Okay, takes a few days. Vaccine don't work immediately. This is the randomized data. Totally believable. It also shows you that by the time you got dose 2 on day 21, your risk is already pretty floored. It's very difficult to know the additional value of additional doses. That's a point I always want to make. Okay. This is the Israeli data, the observational data from Israel. Here they're not looking at getting SARS-CoV-2. They're looking at dying from SARS-CoV-2, from booster, no booster. Where do the curves split here? From dying from SARS-CoV-2 for people who got 3 doses versus the people who got the 4th dose, the second booster. And I would argue that the curves start to split on day 9. So here you're telling me you don't even see a reduction in symptomatic SARS-CoV-2 for like 7 to 10 days after after a shot. And here you're telling me, but reductions in death, which happens after getting the disease, they occur even sooner? And Anil Makam, who's a faculty member here, said this is not plausible. This is too fast. The antibodies have to go up. There's an incubation period. There's a lag because you have to get sick with COVID and be hospitalized and be put on the vent. And typically, you start to die like a week later. You're not dying on day 10. It's separating too fast, he's saying. And I agree. Okay? So I think what it means when it separates too fast is the same thing it means when it's a falsification endpoint. It's a type of it's that it's not plausible. The reason it separates too fast is that the people who get the booster are different people. They've already avoided getting COVID in the days prior to getting the booster. Okay. Eric Topol, he makes this mistake all the time. Here he is publishing that COVID-19 vaccine reduces the risk of long COVID. Look at when the curves split. COVID-19 vaccine, it prevents long COVID before it can even prevent you from getting COVID. How is this plausible? It's not plausible. This is an observational study. And the reason it's not plausible is that people who, this is people who have long COVID and getting better from long COVID it cures you of long COVID immediately. It's a placebo effect. That's the only way to explain it. So we have this paper called Detecting Selection Bias in Observational Studies when Interventions Work Too Fast. If interventions affect endpoints that cannot be plausibly related to the intervention, or if they work too fast, then I think that's a fair sign that there is residual confounding in observational studies. Here is Eric Topol on Paxlovid, which he thinks is so wonderful, 85% reduction in death, and look at the curve split instantly. Paxlovid works even before you take it. It's already prevented all-cause hospitalization, even before. Of course, some of this is guarantee time, because you can't, in order to fill the Paxlovid prescription in the community, you can't be in the hospital. But some of it is also residual confounding. The type of person who rushes to get Paxlovid is different. Okay, so I've summarized this in a paper I've written called COVID-19 Vaccines, History of the Pandemic's Great Scientific Success and Flawed Policy Implementation. I think it was a success for an older person who had never been exposed to COVID-19 to get that first dose. That was life-saving in the first quarter of 2021. But I also think that repeated doses in younger populations, boosters in children, these are extremely flawed policy implementations that at best have a very poor cost-effectiveness ratio, but at worst are actually net deleterious. And I think many of the reasons why we do it is because of some of the sort of structural problems in observational research. All right, I will pause there. Future things to explore, I run a YouTube channel, and then I host some Substacks, Drug Development Letter. I have a podcast called Plenary Session, and we have our laboratory where some people from it are here. So I'm going to pause there.